Hi, welcome everyone. I see that folks are joining us. So before we begin our conversation with our panelists, I'd like to mention a couple of housekeeping items. Live interpretation is available for today's webinar. To activate the translation function, go to the bottom of your screen, click on the globe, and select your language.
Hola, buenas tardes. Veo que ya las personas se están uniendo. Antes de comenzar, quiero aclarar un poco de logística. Hoy vamos a tener interpretación en vivo al español. Para acceder a los servicios de interpretación, deben ir al globo que va a aparecer en el fondo de la pantalla o los tres puntitos que dicen más y seleccionar su idioma de preferencia en el menú desplegable bajo interpretación de idiomas. Si tienen alguna duda, pueden escribirnos en el chat. Thank you, Iván.
Thank you. And if you have a question, please enter your question in the Q&A function, and we will answer as many questions from you as possible after our moderated conversation. So welcome again to Fairfield County Talks Housing, the intersection of health and housing. Fairfield County Talks Housing is a program of the Fairfield County Center for Housing Opportunity. I'm Yvonne Klein, and I'm founder, and I'll be your moderator today. Fairfield County Housing provides fact-based conversations with the experts and leaders in the fields of housing, affordable housing, and zoning. When it comes to housing, people always say location, location, location. When it comes to selecting a home for its value, school system, open space, and it's just as true for your health. Where you live, your zip code, right down to your neighborhood and your street can shape your lifespan, your risk of disease, and your mental well-being. In fact, those of us who live in the suburbs have longer life expectancies than those of us living in the cities. If you are homeless, your risk of disease and mental health challenges are greater than someone who is stably housed. But it doesn't have to be this way. So today, along with our panel of experts, we're going to delve into the data, the details, the policies, and hear about what's happening in Stamford that's creating healthier communities. With that, it is my pleasure to introduce our panelists, State Representative Cristin McCarthy Vahey and co-chair of the Public Health Committee, Dr. Danya Keene, Associate Professor of Social Behavioral Sciences at the Yale School of Public Health, and Vincent Tufo, the Chief Executive Officer of Charter Oak Communities in Stamford. Hello, our panelists, and welcome. I'm excited to get going here. Danya, we're going to start with you this afternoon. So, Danya, you've done extensive research on how housing policy, and neighborhood conditions drive health inequities. You are also a member of the Housing and Health Equity Lab at Yale. Please talk to us about the implications of neighborhood conditions and other factors that you would like to focus on that drive health inequities.
Thank you. Happy to talk about this things. Thank you for having me as part of this panel. So I'll just say that our Housing and Health Equity Lab at Yale is focused on understanding how we can leverage housing policy to advance health equity and also how we can leverage health data to support more equitable housing policies. And the main thing that motivates this work is really the serious unmet need for affordable housing nationally and in Connecticut. And just to put a number that may be familiar to everyone in this room, but here in Connecticut, you would have to work 88 hours per week at minimum wage just to affordably rent a 2-bedroom market rate apartment, which I think we can all agree is a completely impossible amount of work and really makes housing out of reach for many Connecticut residents. So this lack of affordable housing contributes to multiple forms of housing insecurity and precarity that affect health. So first, these huge cost burdens where people are spending too much on housing often come at the expense of other needs like healthy food, or at the expense of sleep when people are working multiple jobs just to pay the rent. This lack of affordable housing also contributes to evictions when people who are paying just too much inevitably fall behind And it also contributes to poor housing conditions when tenants have to settle for low quality housing or have to live in neighborhoods that contain a lot of health risks because there isn't anything else available. And as Yvonne mentioned, this lack of affordable housing also contributes to homelessness, which has really increased substantially across Connecticut in recent years and is putting huge strains on our emergency housing and homelessness sector. So in our lab, we think about how all of these dimensions of housing insecurity affect health through many mechanisms, including extraordinary amounts of stress that we know is really toxic to the body and contributes to chronic health conditions and premature aging. And another key thing that we focus on in our lab is moving beyond the individual. So there's a lot of research that shows how someone's own housing affects their own health, which is kind of obvious. But research also shows that when one person loses their housing, the effects of that can actually reverberate through networks, through families, and through entire communities. So for example, we know that high eviction rates can strain community resources like schools and hospitals. And likewise, there's recent research shows that protections against eviction, as one example, can have huge community-wide benefits in terms of infectious disease, mental health, and even a recent study shows how community protections against eviction can affect birth outcomes at the zip code level. And another kind of focus of our work and something we emphasize is that these community burdens of housing insecurity, they are not borne equally owing to an ongoing history of racially discriminatory housing policy that has really structured access to home ownership, access to wealth building opportunities, and really importantly has structured access to the neighborhoods that contain resources that families and individuals need to thrive and to be healthy. And for that reason, I'm at a school of public health, and I think about housing as really a primary mechanism that underlies these vast racial disparities in health that we see in the U.S.
Great, thank you so much. So as you've mentioned, and we've mentioned, you've done a lot of work, looked at some of the areas that you've been studying. And, always in research, sometimes you have surprising results. So I'd be interested to hear what findings have surprised you the most?
Sure, that's a great question. And some of this research is not surprising. I think it's not surprising that not having a stable, healthy place to live affects health. And it's just, we just need more data showing how strong that relationship is. But I will share one surprising finding from a recent study. So we've been doing a lot of work looking at the health effects of rental assistance, these rental subsidies that come in the form of either vouchers or project-based assistance. They're really important sources of affordable housing because they set tenants' rent to 30% of their income. But as many people in this room probably know, these subsidies are incredibly short supply. There's tens of thousands of people in New Haven alone on waiting lists, and people really wait for years. So that has allowed us from a research perspective to compare people who are waiting to people who receive these subsidies and really look at the impact on health. So when we do that at the national level, the big takeaway is that the waiting group has significantly worse health outcomes, which is not surprising. So for example, our team has found that the waiting group has more uncontrolled diabetes, worse mental health, worse food security, and they even eat fewer fruits and vegetables than the group that has rental assistance. So these findings really underscore how investments in affordable housing matter for health. And I think the catch and sort of the surprising part to some people about these findings may be that when we break down those effects by type of subsidy, the positive impacts are really really driven by the project-based housing, and there's much fewer positive effects for the voucher recipients, which I think can be surprising because vouchers should theoretically provide more choice. And when we drill down to the local data and we actually interview people in Connecticut who have been waiting for these subsidies and then go on to receive them, we see a more complicated picture where for some people, getting off this waiting list and getting that voucher is really a godsend. It is like transforms their life in their health. And for others, it's a lot more complicated. They get that voucher that they've been waiting for years, and then they cannot find any unit to rent with it. They look for months, and finally, because the voucher is going to expire, they end up settling for a place they didn't want to live, a neighborhood that has health risks and doesn't have the resources they need, or a unit that has really severe, serious code violations or health harming conditions, lacks appliances, has rodents, mold, things like that. So I think that complexity can kind of help us unpack those national findings, and I think was a little bit surprising.
Great, thank you. What are the gaps in Connecticut's housing policy?
Yeah, and so that's a really big question, and I think we could spend all day answering it. But I think, going back to the example that I just shared, I think that example really highlights that there's not one solution. This problem is so big that there's not one silver bullet solution. And just for example, providing everyone with rental assistance, if there aren't units available that have good conditions, that are in good locations, is not going to be enough. We need to do both things. And we've done, our lab has done a lot of work looking at other housing policies like right to counsel and other eviction protections. And we see that kind of pattern across the board that the solution, it's never one thing that is going to address this problem, that it really needs to be addressed from multiple angles. And we all kind of need an all hands on deck approach to solving this issue.
Well, and I appreciate that answer, because I think we know, and the folks, in the audience also know, that there is not a magic bullet. And the more we repeat that, the more progress I think we can make in addressing our housing situation in Connecticut. So, Cristin, Representative McCarthy Vahey, I've got some questions for you. So as a state representative, you represent parts of Fairfield and Bridgeport. Overall, we are all of us Connecticut residents, we are fortunate to live here. We are a state with a relatively high life expectancy of almost 81 years. Within the state, Fairfield County often ranks among the highest life expectancy at almost 82 years. But there's a striking difference even locally. So if you live in Fairfield, your life expectancy is about 82.2 years. But if you live in Bridgeport, it's a little less than that, at 77.7 years. What factors do you think help explain this significant gap in life expectancy from suburbs to cities?
Yvonne, thank you so much for having me here today. And thanks to everyone from the Housing Collective as well. Danya, it was wonderful to hear your remarks. We use the term social determinants of health quite a bit, and it's kind of a wonky term, but what does it mean? It means, where do people have access to healthcare, to food, and of course to housing? And Yvonne, you use the Fairfield Bridgeport example. I'm going to use a little bit more of an extreme example. The Connecticut Health Foundation actually names two communities and talks about the difference of the racial makeup of neighborhoods. And that, of course, is the relic of years of zoning and redlining, as we see in books like The Color of Law and in policies that have been in place for a long time. And we're still dealing with that. But in a northeast Hartford neighborhood, the life expectancy is 68.9 years. That's a neighborhood where 69% of the residents are Black and 29% are Hispanic. Whereas in Westport, my good neighbors, the life expectancy is 89.1, 91% white. I bring that up because certainly the impact of housing segregation has impacted those factors, and that's, I think, something that we really need to be mindful of and talking about as we talk about these issues. The things Danya talked about, economic stability and the concern about how you'll be able to pay your bills, of course, the housing itself and the type of housing and the safety of housing and the environment. We look at asthma rates. Certainly, we have across Connecticut some of the worst air in the nation, but those asthma rates are particularly much worse in our urban centers. And again, the Health Foundation data, Black children 5.5 times more likely to go to the ED due to asthma and be hospitalized. And if you're Hispanic, that's 4.5 times more likely than a white child. And again, these issues do cause a significant amount of stress, and Danya talked about that. Stress, mental health concerns, substance abuse concerns, um, definitely all part of that. And then something else that I talk about often, transportation is my first love. It's the committee in the legislature I've served on the longest, and then was chair of planning and development prior to being public health chair. And as a social worker, putting all those pieces together, walkable communities where there is safety and of course accessibility to food. But when people don't have the ability to be able to walk freely and safely and move around their neighborhood without having to have a car, with being able to have access to transit, being able to feel safe in their neighborhoods, whether it's safe on a roadway or safe because they're worried about, different kinds of violence, all those things make an impact too, just in terms of our health and well-being. So, Danya talked about things like mental health, diabetes, and obesity. It's a lot easier to deal with all of those things. Walkability and access to being able to move freely in a place that is accessible is really important.
Great, thank you. And thank you for bringing those other statistics from other parts of Connecticut. I really appreciate that. What legislation has been enacted that has influenced or improved the intersection of health and housing?
Well, I'll start by saying not enough. We have taken important steps, and I really want to thank our majority leaders, Representative Jason Rojas and Bob Duff, for taking a lead. But I'm not here to pat us on the back. I'm here to say that we have a lot more to do. I think the big conversation in housing over the past few years really culminated with 8002, which was the bill that happened last fall/early winter. And I think that one is about many things, housing supply being part of that conversation that's so important. And though it may not seem like such a direct intersection with health, we have to have, I try to avoid silver bullet, maybe a more blanketed approach or weaving things together with many different solutions. But supply is a massive issue for us. We're 50th out of 50 in per capita real estate listings in the country. And from 2017 to 24, this is Pew Charitable Trust numbers, we were 49th out of 50 in terms of the number of building permits issued. So we have a long way to go, and that bill, I think, helped get us there. We tried to talk a little bit more about accessory dwelling units this session. We passed a bill when I was planning and development chair that some communities have taken, partial advantage of. We have a ways to go on that. We've continued to address funding. Paying for housing is expensive. Supply costs are up, inflation, wages are up, but we have been able to fund and provide options again for supportive housing, so important, deeply affordable housing. The opioid settlement fund, actually, this isn't legislation, but provided some of those funds towards supportive housing for people dealing with abuse. A smaller issue, though very significant, and I say smaller because it's really asking for a recommendation, but in public health this year, we addressed the extreme weather protocols. This is something that's really important. Believe it or not, more in hot weather, more people die in the heat than in the cold. We tend to think about it in terms of the cold. But to make sure that those protocols are properly communicated and that the agencies working together with the homeless community are really in sync with what's happening at the state level agencies. We've expanded the fair rent commissions in 8002, which is, again, something important. We didn't quite get there with Just Cause. Actually, we didn't get there, period. evictions, and that's something we need to continue the conversation on. And then another example, I'll just give a shout out to the folks on the east end of Bridgeport. We passed a bill in public health called the Triple Bottom Line, Brownfields to Health Fields. So when you look at our environmental justice communities, where people in neighborhoods have been impacted by toxins and pollutants that some of our perhaps more rural or suburban communities have not had impact. That is a neighborhood group working together with Yale to look at impact of the environment, housing, health, and economic development. So those are some of the bills or policies. But like I said, Yvonne, we have a long way to go, and I think there are a lot of us committed to continuing moving in the right direction.
Thank you. You had mentioned homelessness. So homelessness in Connecticut is increasing. I think Danya mentioned the increase in homelessness as well. And homelessness is considered a public health crisis. Why is that? And further, what effects does homelessness have on mental health, the education of school-age children, and physical health? I know you touched on some of the physical health, as did Danya. So if you talk a little bit about homelessness and its effects and why it is considered as a public health crisis.
Thank you so much for that. And I'm thankful that we are having this conversation and bringing things together. And before I answer, I'm just going to talk about how we work in the legislature as we work by committee. So we have our agencies that we have cognizance over or with, and sometimes things get siloed. So, whether it's something like the extreme weather protocols, which is really a public safety function, or, Department of Public Health working with the Department of Housing. And while our agencies work together, sometimes as committees, we don't always do so. So we don't tend in public health to have as direct conversation about what's happening with our homeless population. We have a new homelessness caucus, and thanks to Rep. Roberts and Rep. Sweet for leading that. But, public health or homelessness as a public health crisis, there's the lack of access to care and services is really one of the first things that I think about. It's hard enough to get health care when you have an insurance card and benefits. And, anyone on this call who is fortunate enough to have insurance knows that you can struggle with that. The ability to have a primary care provider and have prevention as opposed to using the emergency department for your care. And when you go to the emergency department, you are getting the reaction, of course, great care in so many of our hospitals, but you don't necessarily have the kind of follow-up. And again, the prevention costs increase as well, which is just another strain on the system. When you're talking about accessing benefits, many of our homeless population experience disabilities of some sort, and it's difficult for anyone to access disability benefits, and for the homeless population, it can be even worse. 28% of the population versus 10 to 15% of the homeless population who are able to successfully get access to some of those federal benefits. I think the role of substance use and mental illness, and again, access to treatment and care. I should have mentioned, we passed a bill in public health this year to allow our emergency departments to provide bridge treatment, particularly for those with opioid use disorder. Not to have them, use the ER as a place to get treatment, but if someone's going into the emergency department, to be able to have that bridge. But I also think, Yvonne, when I think about this conversation around homelessness, I think a lot about changes in the federal policy that have gone away from housing first. And I think what comes to mind is the word worthiness. And that is a concern because everyone is worthy and deserving of housing and healthcare. And these two things come together to create a real crisis for us. And we are seeing the impact of all of these basically lack of addressing the issue in a significant way. And now the pressures on our housing market, and we just continue to see the human cost and the human suffering and the health of the people. It's impossible to stay healthy in the way that you need to be when your body is physically, mentally, emotionally, spiritually stressed in every way as you're just trying to find a place to safely stay for the night.
And thank you for bringing up housing first. Connecticut, for many years, was a housing first state. And when you have a home, things come, right? You can get a job, you can go to the doctor, you have a community around you, you can stay healthy, get sober. So housing first in so many ways is so beneficial, obviously, to folks, and able to get them back on track or keep folks healthy. In Connecticut, when we've had been able to move people from housing to homelessness, we've had in the past a very high success rate, which is really important to creating healthy communities and a healthy state. So thank you for raising that issue. And there are many folks, I think, on the call and in the audience who also believe housing is a human right. So bringing up the issue of worthiness is also really important, making sure these concepts remain in our conversations in all respects when we're talking about housing. So I appreciate you bringing those issues up. Vin Tufo, we're going to go to you to have, you're doing things in Stamford that we're talking about here that we should be doing. So you've launched an innovative and impactful initiative in Stamford with the Vita Health and Wellness Partnership. Please tell us about the Vita Health and Wellness Partnership and what inspired you to create this collaboration.
Hi, everyone, and thanks for inviting me. I'm always happy to talk about the Vita Partnership and really enjoy listening to the other speakers. And I'm listening for and hearing so many threads that really do connect on several levels, both at a sort of a process level, production level, and a system level. So this is really great. And I hope that I can help to weave those threads together a little bit. So as Yvonne said, I'm the CEO of Charter of Communities, which is the largest provider of affordable housing in Stamford. Stamford is the highest cost housing market in Connecticut, municipal housing market, with significant health and wealth disparities. So we're kind of in the middle. We're in the crosshairs. We haven't had a successful program. We've been working very long on this program. I've been here 30 years. And our approach is really to improve upon an essential inventory portfolio of affordable housing that was here when I got here, but it was in dire circumstances. People were not doing well. The buildings were not doing well. The neighborhoods were not doing well. So we said, how do we double down? How do we invest in this? So along came Vita, and I'll give you a quick overview and then talk about what inspired before I get into any more detail. Because I think it's important to know kind of where this comes from and how it still sort of is generated. So Vita is really an asset-based approach to reducing inequity and solving complex social problems. I think if you listen to Danya's discussion at the very beginning, she was really talking about system-level complexity that is really at the heart of why we have so many people in the state of Connecticut that are experiencing multiple challenges coming from a variety of different directions, whether it's health, being in a minority community, being uneducated, certainly having housing challenges and so forth. But all of those things conspire to create very, very complex challenges, social and economic challenges that hold people back, that reduce the upward mobility, that reduce the likelihood for self-sufficiency in education and so forth. So Vita is a program that employs collective action, aligning multiple community service organizations to fulfill Stamford's commitment to healthy living by addressing the social determinants of health that Cristin mentioned. Serves as a backbone organization. And if any of you know anything about or have worked in collective impact, you know that one of the most essential components is to have a backbone organization that's able to pull together a number of organizations, but more importantly, a number of objectives to sort of create a set of common and shared objectives, and then to support them in a collaborative way, rather than just simply saying, well, we all agree on these things. Well, how do you get together to align resources, to align actions, to align objectives, to align metrics, so that these things can really start to develop into viable long-term programs? So I'll jump over to what inspired VITA. Well, it was really kind of things that were out of our control, and that's all good things happen when you're not kind of pulling all the levers, but you're kind of in the middle of change. So the first change occurred in the late 1990s when the Department of Housing and Urban Development, HUD, created a program called Hope 6. And some of you remember or know or heard the term Hope 6, which was a program for the revitalization of severely distressed public housing in the United States. And that meant that housing projects, housing communities that were becoming very, very challenging, problematic, high rates of crime, low levels of education, high rates of chronic health, and so forth, was in need of a total sort of reboot. And one of the really interesting aspects of the Hope 6 program, which a lot of people don't know, is that underlying the theory of change for the revitalization of public housing was to make strategic investments in resident services. This had never been done before in any federally subsidized housing program. You may have senior developments in the 202 program that would have had a resident service component, but the idea that we were not just investing in rebuilding communities, but that we were investing in the most important resource that communities had, which were the residents themselves, was the thing that made Hope 6 so different from anything else. And even in the application, the grant that we received, a large portion of the funds and more funds that needed to be leveraged and partnerships that needed to be formed were to create a robust resident service initiative. And that's what Charter Oak Communities took, if you will, took to heart, took to task. And we've been applying that for all of our developments, even non-Hope 6 developments since then. And as I said, this goes back close to 30 years. So the changes that we've helped to initiate here in Stanford has really become the basis for the way in which we operate affordable housing. The next thing that happened, which was also not planned and not under our control, was the Affordable Care Act. So maybe some more folks on the call know a little bit more about the Affordable Care Act that was formed in 2010 in the Obama administration. And among other things, not only the ability to receive insurance premium subsidies, in other words, to make insurance more affordable, was something called community benefit that all nonprofit healthcare institutions needed to participate in order to qualify for their benefits under the Affordable Care Act. So what that meant is that healthcare institutions needed to conduct community health needs assessments. They needed to focus on the population that was most in need within their catchment areas. They needed to invest in community benefit and partnerships, and they needed to focus on population health improvement, not just being a reactive center, what they could even call a repair shop for folks individually, but to really get out in the communities and for many of them, for the first time, really become very active and proactive in stimulating community health. So with these two sort of very major sort of dynamic forces, we created the VITA partnership in 2010 with Stanford Health as being our first partner. And Stanford Health has been one of our benefactors ever since, but from growing from just a handful of partners, we are now over 100 organizations and individuals that serve every need, every possible need of the community in which we operate, from mental health, physical health, education, economic development, food, community conditions, criminal justice, housing, and many, many other things. So essentially, we become the community service network for the city of Stanford. And before I know Yvonne's got a couple of questions, I just wanted to give you just 3 more details about VITA, because the natural question is, how does it work, right? It's not just a great idea or an idea. It's really a mechanism. So it really has 3 major components. You might say 3 legs of the stool. One is that, and any of us that have worked in the social service sector know that it's inherently siloed. that it has a certain sort of undercurrent of competition, and that organizations, while they know each other, don't necessarily play in the same sandbox or play well in the same sandbox. So what Vita really said is if we're all part of this one, let's say, set of objectives, let's figure out a way to get to know each other, to establish rapport, to establish trust, and to create a network that was enduring and that would essentially be sort of ever growing, evergreen. And so what I see when I look at our networks and the effect of the network is that we see many key individuals, in other words, people that have been doing this work for even longer than I have, if you can believe that, that are working outside of their organizations together. In other words, not with respect to I'm the executive director of X and I'm the program director of Y, and that's where my main focus is, but where these, let's say, interagency collaborations occur at a very high level, and certainly where great ideas come together and great solutions are developed. The next thing, which is again part of the underpinning of Vita, is that we're a very robust information exchange. In other words, being part of the Vita network is essentially going to school and learning not only about your own, let's say, sector or discipline, but learning across disciplines. Because what makes us better partners is to really understand and have context in areas that intersect. So if you're a healthcare provider, some of the areas that will benefit any practitioner in physical medicine is knowing more about mental health, or knowing more about social conditions, or knowing more about where people live, or knowing more about what they eat, all of the things that were talked about earlier in this webinar. So how do we make sure that those providers are well informed and that the information is current, it's relevant, and it meets their needs to be better informed and better able to practice in their own disciplines? The third area, which is the most exciting, is program incubator. So what Vita does is look for opportunities where we need to fill a particular need, and we help to develop, we sponsor, we help to facilitate cross-sector programming. And I'll just give you one quick example of that. And that is where we started to work with our preschool providers in the city. And Stanford, as many of you know, has a very large immigrant population. In fact, we're more than 50% foreign born at this point. And what we found is that folks that had kids entering preschool at 3 years old were already struggling with an achievement gap that was only going to get wider before they went into the conventional public school system. And part of it is because of the lack of language, English language in the home, the lack of education in the home, the lack of understanding as to how to prepare their children, their 3 and 4-year-old kids, for the public education system in the United States. So we created a program based on the Parents as Teachers model called Parents as Co-Educators. And so it was as much working with the parents to help them understand, get up to speed, participate, and support their kids' preschool education. And one statistic that continues to blow me away, and this program has been going on now for over 10 years, is that using all the metrics of the State Department of Education that were relevant, we found that kids that came into the program starting with a roughly 30-point achievement gap, in other words, an achievement deficit, in most cases equaled the achievement level of their white and general population peers, and in many cases actually exceeded them. So what we did is we actually went from an achievement gap to a negative achievement gap when these kids entered kindergarten, and the results from that point on were unbelievable. So that's just one example of a Vita program.
Excellent example. And you skipped ahead a little bit, but I was going to ask you about what outcomes you have seen. You could certainly add to that if you'd like. But I think, how can this be replicated and where should it be replicated? I think we all have our own ideas on this, certainly the wheres. But if you wanted to give another example on outcomes, that would be great. If not, that was a terrific one. But how can this be replicated and where?
Well, my belief, it should be replicated everywhere. I think that it really exists as kind of an undercurrent of many of our hopes and feelings that we can do better for underserved families and to resolve structural inequities that exist in our system. And the only way to do that is to, first of all, take stock of the fact that, as I said earlier, and again referencing Danya's comments, that we're dealing with very complex challenges. These are not challenges that are generally resolved by one solution, even providing someone housing. And I think it was even referenced, Cristin referenced, that it's not just about getting people off the streets into housing, but providing access to services. So right there, you're creating a need for coordination, for recognition, and for bringing diverse resources together. So if there's a community and communities that are starting to feel that we have done a lot and maybe not even enough, but we can do more, what you do is you figure out who needs to be at the table, help to organize around, again, developing trust and rapport, learning from each other, and then starting to essentially roll up their sleeves. And again, very little incremental funding that would need to go into this, but it is a way to establish let's say, a resource or a facility in your individual communities to deal with the social determinants of health.
Great, thank you. So what does the future of VITA look like?
Well, it's funny, we're kind of getting bigger and bigger where the issues keep getting sort of brought to us. One is on elderly mental health. So those of us that are even in the homeless sector know that the largest and growing, most vulnerable population is in the elderly population that are increasingly vulnerable, not just vulnerable for housing, but vulnerable because of social isolation, vulnerable because of chronic illness, vulnerable because of lack of access to healthcare and other resources. And so what VITA is doing is really going after parts of the population that have very significant needs, but where the solutions are kind of right there. Another is youth mental health, where we've had a Youth Mental Health Alliance for the last few years, but the challenge continues to change, where we're now talking about sports gambling in the 17, 16-year-old population. That's becoming much, much more difficult for the, let's say, the conventional behavioral health infrastructure to deal with. So the future of VITA is to continue to focus on and address the current and emerging challenges. I think the other, let's say, sort of future focus is how we can sustain the kind of effort as leadership changes within different organizations so that you have the kind of buy-in and continuous support that these partnerships need to endure over not just years, but in many cases over decades.
Thank you so much. So we have folks in the audience. Before we go to the audience questions, what role, and this is for everybody, so if Cristin and Danya, if you could put your cameras back on, what role can we play as advocates, concerned community members, professionals? What role can we play to create, I guess, maybe a better intersection, a stronger intersection of health and housing? Cristin?
I was going to say I'm happy to jump in on that one.
Jump in.
First of all, never assume that your policymaker knows or understands your issue intimately. I often, in the Public Health Committee, when we have people testify, ask people to repeat what they're saying at the fourth grade level, not because I or my colleagues are operating at the fourth grade level, but because the sheer volume of issues that are before us, even if we serve as a chair or a member of a specific committee, is pretty significant. And so I think that's really important. I think continuing to develop relationships, what Vin just said about the future of the work with respect to relationships and building those relationships is really very, very important. And inviting people to, policymakers in particular, to come meet you where you are. I was a youth minister, I'm a social worker. There's nothing like just getting out and seeing what's happening on the ground. And, I should also give credit to Senator Amor, who has been a real champion around the issues of housing and homelessness as well. And I do think that that's really significant. But again, don't assume that we know or understand. And also then when building that relationship, making the specific ask.
All right. So I'm going to go to some audience question. Where is the deeply affordable housing being built? Cristin, do you have
I was
an
going to
idea?
say, I think this one might be me. I think we're really struggling with building deeply affordable housing at this point because it's math. As I joke with my kids, everything becomes a math problem. So when a builder or developer is building housing, they effectively need to make a profit. And if they're not going to make a profit, they will need subsidy funding. And so obviously that deeply affordable housing doesn't provide the same kind of return on investment and profitability. So that means state funds. So, here in Fairfield, for example, over the years, I've heard people say, why can't we build the density in our cities? And I'll go back to the conversation that I was having with you earlier, Yvonne, about, segregation and the role of racism in public health and housing. So here, I'll use one example here in Fairfield. Our Fairfield Housing Authority is working now, hoping work has begun on a new housing authority project that will provide some deeply affordable housing. But I think, Danya, you talked about the wait lists. It's scratching the surface. It's very important. It will be a very significant and important project in Fairfield, but it doesn't even remotely begin to meet the need. We know that there's need in every corner of the state. But for example, in Litchfield County, it's incredibly expensive per unit to build. So I wish I had a great answer. We're building deeply affordable housing everywhere. And also, again, back to I'm not the housing committee chair, so I'm not as intimately involved in the day-to-day. But there is work being done in communities in partnership with organizations, housing authorities, nonprofits, CHAFA, to provide support because it doesn't happen and it can't happen without that state and federal support.
Right. An important point that you brought up, housing authorities, as we all know, house the lowest of low income individuals and families. If not for them, some of our people would be homeless. So thank goodness for our housing authorities. And there is state funding at the Department of Housing to assist developers to build affordable housing and to fill those gaps. So, I mean, that's all good news that there is, funding out here, and Connecticut tends to do, I think, be more generous with funding to assist in building affordable housing. Vin, when you reference affordable, who is it affordable for? Can you speak specifically, for example, to a senior with an income of $41,000 per year? So what's your affordability?
So we're getting to sort of deeply or near deeply affordable housing. So connecting these last two questions, what we do is, and we started with a large portfolio of federally subsidized public housing. What we've done in many cases is we've redeveloped or replaced that portfolio, but kept the subsidy that was originally attached to it. So it's that deep subsidy. And I understand you were talking about two types of subsidies. One is the one you were mentioning, Yvonne, which is capital subsidies. In other words, writing down the actual cost of building the development. The other is an operating subsidy, which, when you're talking about deeply affordable, is probably the more important one. Because what you've got to do is to take a unit, housing unit that's, let's say, would otherwise rent for $1,500 or $2,000 a month, and write it down so that someone should only pay 30% of their income. So that person that's earning, let's say, roughly, $1,200 a month, I suppose, is the number that that you outlined, no, more than that, would be about $3,000 a month, should be paying less than 30% of their income. And they can do that if we can put an operating subsidy on that development. So what we're doing is we're using not only the original operating subsidy, but also project-based vouchers, tenant protection vouchers, emergency housing vouchers, and other types of housing vouchers, again, operating subsidies, to make those units affordable to the deepest level, to the woman, let's say the single elderly woman at $41,000 a year, but also someone on SSI that's earning $21,000 a year. So the idea, I think, is to pair housing development with the opportunity to bring in operating subsidies. And we also, I want to throw a shout out to our local homelessness provider, Pacific House, which is doing amazing work to build permanent supportive housing in Stanford, in many cases without subsidies. And they are using your capital subsidies. In other words, they're getting a significant amount of money from CHAPA, from DOH, from private sources, and that's able to sustain deeply affordable housing for that population.
Thank you. I want to be mindful of the time. We have a couple of more questions. And Cristin, well, I think you all might be able to answer this one. I had mentioned that there's funding at the Department of Housing, and those are in the form of, that funding is a form of grants. But what state level grants are available to support housing and health initiatives? So this is a little more of a direct line. Do you know of any offhand if there are state level grants?
So I don't want to interrupt Danya or Vin. If you wanted to, I can start. Again, I'm not as conversant in all of the variety of programs. That's where I lean on my housing committee chairs and our team at the Department of Housing. But one thing, I know there was another specific question about the CHESS program, the Connecticut Housing Engagement Support Services, the initiative through what had been the Department of Social Services and has now, because of issues with that program in particular, things have been moved over to the Department of Mental Health and Addiction Services, and there will be work with them through their supportive housing mechanism to make sure that, I believe most all, if not all, I don't think it was actually everyone that was able to move over, but I think, again, I mentioned the Opioid Settlement Advisory Committee funds as another innovative program. Again, these are important steps and they're beginnings, but I know that there's much more, and I'm sure, Vin or Danya may have other answers as well.
If not, that's okay. Anyone? Okay. How can friends and family serve as a support network for those with unstable housing? What suggestions are practical to share with the public, knowing that housing or supporting housing for others is a burden that has ripple effects?
I can
Danya.
take that one.
Okay.
We actually, recognizing that a huge safety net for people who are struggling with housing affordability is friends and family. And we saw in our research so many friends, family, acquaintances who were filling these gaps in our state-funded social safety net by providing housing. And so we wanted to explore what that experience was like and what the sort of costs were, and to think about these ripple effects. And one thing I think our findings were less about what those individuals can do in providing housing, because people are doing so much, and more about what our policy landscape can do to support people who are providing housing for their friends and family. So one thing we learned is that people are often taking in a friend or family member or an acquaintance and risking their own housing stability because they're violating the terms of their lease in order to do that. And so I think those are places where we can look upstream and say, how can we recognize the support that is being provided, or whether there's funding that can provide support for these informal housing providers, because they really are playing a huge role in our housing safety net.
And may I add, Yvonne?
Yes, of course.
Just I know we hear a lot about, oh, there are a lot of legislators who are landlords. I've talked to legislators who are exactly those family and friends who are supporting people who have housing instability. So this is an issue that impacts many people. I think one of the things that I've heard co-chair Felipe talk about is, at what point in their housing instability journey are people able to qualify, kind of those definitions and the thresholds, so to speak. So because of resources being limited, we kind of wait until people are pretty much over the cliff before we take action versus how can we, from a policy standpoint, go farther upstream and look at things before people are at that cliff or, going off the cliff. But I also think just to recognize and name the unbelievable stress. Um, I have a family member in another state we're headed down that road. And I have to say, and I have, as you all know, many resources available to me and people I can call for advice and other resources. And I think about it every day. And it's coming. I see it coming. And I don't like to use myself as an example because it's ridiculous, the wealth of connection and opportunity that I have. But if I'm experiencing that, what is it like for someone who has a family member who's living in their car or moving from basement to bunk to wherever? It's just the physical, mental, again, emotional stress. It has health impacts. It has real health impacts.
One last, we have time for one last question. Regarding housing and health connection, can you please tell us anything happening on the state level to address food insecurity as connected with unstable housing? I know, Cristin, you had passed some funding for SNAP, but what else has happened? And anyone else? How are we doing with food insecurity in Connecticut?
So, oh boy, we are finding more and more issues are happening, and I expect that we will continue to see more. Again, this is where the federal impact really does make a difference in people's individual lives. I will thank all those who helped when it comes to school-age children, and I really never addressed that part of your question, Yvonne. What it's like for families who have children and they're trying to educate and feed their children. We now have in Connecticut universal school breakfasts, and I know the lieutenant governor and others have talked about working towards the lunches for next year, so at least at school. We, as the Medicaid Oversight Committee, MAPOC, have been hearing from DSS, and I know the Human Services Committee, about how to address some of those new requirements for SNAP and what we have to do to address our fraud numbers to make sure that we're not losing any further funds or being penalized. And we're having to invest a lot of state resources, time and dollars into that. It's significant.
Well, thank you. Thank you all. I'd like to thank our panelists, our audience, and to our sponsor, the Housing Collective, and our partners in Fairfield County's Community Foundation and Local Initiative Support Corporation as we work together to deliver safe, equitable, affordable housing solutions for families and individuals across Connecticut. So thank you again, and thank you all for joining us, and see you all soon. Thank you.
Thank you.
Thanks, Yvonne.